Good afternoon, everyone, and welcome to our neuromodulation panel. We have a very exciting panelists with us today, and I'm sure all of you have been able to partake and attend their really interesting talks that were pre-recorded. Most of them are here, so we're going to get started because we have a lot to cover, from in vitro neuromodulation all the way to patients. So because we have a limited amount of time, and we want to make sure that each presenter gets the chance to be able to answer at least one question from the chat, which was really on fire, and a lot of questions, a big list of questions. We're gonna start with the order of the talks and make sure that if we have time, we circle back, but at least we cover all the presenters. So the first presenter was David Attali. And one question in this very exciting talk, the NHP and the anti-saccades, was whether the trials were randomized between monkeys, and whether you saw a dependence of the effect with the acoustic parameters, if they were changed. David?
Hi, everyone. Thank you, Elisa, for those questions. The first question is if the trials were randomized. The answer is yes. Clearly, we did everything we could to ensure that there was no learning effect throughout the process. So there is a randomization of the trials between left and right. And the other question is about the parameters. Actually, we tried two setups, two sets of parameters in this experiment, which took place quite a few years ago. It was before we did all those exciting experiments with Lennart and Pierre Pouget. It was the first time we tried to induce a sustained and reversible effect on monkeys. And we tried at first to do a 40 seconds stimulation. But with this setup, this first setup, we weren't able to see a return to baseline. And it was very important to us to be sure that this was a reversible effect with a return to baseline. And this first experiment was a 30 minutes one. And during those 30 minutes, there was no return to baseline with a 40 seconds stimulation. So what we did is we tried to do a 20 seconds stimulation, like it is in the paper. And with these 20 seconds, we could see a return to baseline after about 20 minutes. So that's the only two sets of parameters we tried on these monkeys. And later with Pierre Pouget and Lennart on the wonderful team, we tried the 40 seconds stimulation on some other monkeys. And then we saw an effect which lasted about 2 hours. But it was too long for this one, so we did a shorter stimulation.
So you just changed the duty cycle. You didn't change the frequency or the pulse duration, for example, just the duty cycle itself.
No, the duty cycle was the same. It was always 30%.
Okay. Oh, 30%, okay.
The only parameter which changed was the total duration of the stimulation.
Total duration, got it.
From 20 seconds to 40 seconds.
Got it, okay, thank you.
You're welcome.
All right, we'll make it back to you if we have time. Thanks so much. The next presenter was Hoon-Chi Kim, who presented also in large animals, in sheep in this case, and found interesting suppressive effects with LIFO. And one question was whether the EMG tones came back immediately after LIFO was turned off. Because there was a mention that EMGs were collected up to 3 minutes after LIFO. And then how repeatable were the observations of the EMG elevations across the 10 animals that you tested?
Okay, thank you for the questions. First of all, I would like to answer the first questions. And the suppressive effects on sheep walking on a treadmill actually outlasted the 1 minute duration of active sonication duration itself and were reversible. as the decreased EMG amplitudes were recovered to the first baseline level in terms of in the time segments of 90 to 120 seconds after end of M1 sonication, while the recovered to the baseline level in time segments of 30 to 60 seconds after end of thalamic sonications. And the second question is about how reproducible were observation. Yeah, okay. Reported EMG response rate actually were group average across the animal. Actually, we did not examine the repeatability of EMG signal for the same set of acoustic parameters. Intra-animal and intra-session reproducibility and variability of signal responses remain to be investigated in future studies.
Okay. Yeah. Thank you very much. It's always difficult with EMG to be repeatable. So I think it's one of the challenges that we have, I think, as a field. So it's good to know that you tested that.
Thank you.
All right. So we have Dr. Kuhn maybe here? Not yet. All right. So if not, we're going to go back to him when he comes, if he comes, and I'm going to pass the baton to my wonderful co-moderator, Song-Shik Yu. Take it away.
Thank you very much. I hope everyone is doing very well. My name is Sung-Shik Yu. I'm the co-moderator for this wonderful neuromodulation session with the Dr. Elisa Conefago. I work at Brigham and Women's Hospital and Harvard Medical School in Boston. So we have to move on to the next speaker here is Dr. Monty from UCLA, who actually reported very intriguing study on minimally consciousness state patient. And the questions that we have here is, do you have an estimate of how long the MCS improvement may last? Dr. Monty?
It's a great question, and the answer is no. We don't have data to it. We can only speak to our follow-ups, which were done up to 6 months, and so far some of the patients do maintain their new classification, meaning they have shown an improvement. Others instead have reverted back. But I have to warn that it is a small sample size. So that question is hard for now to answer. And we hoped by now to have double the sample size. But unfortunately, like everybody else, we are where we're at.
All right, Dr. Monty, I think you answered the question very succinctly. So I probably would like to ask you a second question, if I might. The question is, for the MCS patient, it is often the patient's family who recognize the difference, better or worse. Is there any anecdotal story that you might want to share if it was not really visible from the CRS-R scores?
The one thing that happened very, very often, I'd like to say all the time, but I'll just say very often, we typically have with us the families, because there is data to show that it's family members often can trigger better responses than unknown sort of clinical personnel. And it will happen invariably that the family member will go like, oh, I've never seen that. And that's when we know that we are truly doing something, because we only see them, although very systematically and with existing published protocols, family members are those that see them all the time. So we will very often have a family member say, oh, wow, I've never seen him or her do that. And that's when we know that something is truly changing. Of course, we still do capture these things with CRSRs, but knowing that something is new and never observed before, that really helps us understand the potential of this technique.
Thank you very much, Dr. Monty. I'd like to send the baton back to Elisa and introduce the next speaker.
Thank you, Song-Shik. All right, the next speaker is basically getting to more mechanistic aspects, which is always very challenging and exciting at the same time. So that's Aputun and Jen. And one of the questions, this is very important, and I want to give you a chance to answer, is the parameters, because one thing about our field, that we are challenged with is that we have, all of us report different types of parameters according to what we think is happening. So there was in your table, I believe, one question was that you had hundreds of kilopascals, and I think I also saw some milliseconds, if I remember correctly. So do you want to specify what range you used, maybe, or what did you vary across different in vitro cases?
Yeah. So what we try to do is to stimulate brain cells using a few hundred of kilopascals, so about half a megapascal approximately, measured in free water. And then what's happening in a petri dish is pretty difficult to measure, but it is on our plate to do some modeling of what's going on, especially because we have an incidence angle when we apply ultrasound microscopy, and so this angular incidence is changing also all the reflections that we can create. So we definitely know that the pressure ongoing in presence of those neural cells are certainly higher than what we have measured in free water. But the main point of this experiment was to show a proof of concept that in this range of pressure, which can be maybe doubled in the worst case, we are able to trigger some calcium fluxes that we can monitor with very nice quality. And so we can analyze those results and maybe learn a bit more about the dynamics of neurostimulation by ultrasound.
So what we found also in vitro, it's much easier to cause effects than in vivo. Have you found that the pressures that you use are much lower than what people report in? Yes,
definitely. Yeah, it's definitely lower. We have also studies ongoing on brain slices when we use pretty much the same setup, but using MEA measurement. And so when you go from cell cultures to brain slices, even though it's few hundreds of micrometers, the thickness of the slice, of the brain slice, it's already something which count in the amount of energy that you need to trigger an actual response. But once you have found this minimum threshold, then the trends, the overall trends seems to remain the same. So we find very nice correlation between those different models.
Great, thank you. Thanks so much. Shangshik, back to you.
Thank you very much. Yeah, we have a very nice presentation from the next speaker, Dr. Pavel Novak at Storz Medical in Switzerland. And it was about interesting application of using shockwave of ultrasounds to modulate the brain function. And it seems like it has been applied to Alzheimer's disease patient. So I'd like to read the questions to you, Dr. Novak. One of the question is, it is wonderful and promising work for many AD patients. And it would be great to provide some of the details of the sonication, for instance, frequency, wave propagation map, or the intensity and the depth of penetration?
Yes, it's correct. I mean, the shock waves we applied, there's a focal zone is about 5 centimeters deep from the skull, measured from the skull, from the face of the transmitter. And so we reach with this focal zone, which is about approximately 3 centimeters long, basically the gray matter of the brain. And we treated the areas which are supposed to be relevant for the memory functions. So these are frontal lobe, the parietal lobe, and the precuneus. And in order to achieve homogeneous distribution of energy delivery, we are using a navigation system with infrared camera, and we can have a basically image of the brain, MR or MRI or CT, with overlay of this delivered energy according to the location and intensity, because if you stay on one space, of course, the energy is becoming higher. The shockwave pulses are about 1 microsecond long, but of course, due to the very steep leading edge of these pulses, it's a very broad spectrum of frequencies. So it goes from audible, more or less, till about 20 megahertz.
All right.
The intensity is of the external intensity is up to 25 megapascal. It sounds very high. In the brain, due to the skull, is reduced about to 7 megapascal. But because the pulses are very short and the repetition rate is about 5 hertz, so the mean power density is just 0.1 milliwatt, 0.1 watt per square centimeter.
All right, thank you very much. I mean, this is very useful information. Due to the time restriction, we would like to move on to the next speaker. Thank you very much.
Thank you, Shongshik. So I think we have the last speaker of the session, and which is Leonard Verhagen. And I wanted to also give a chance to Leonard. He's putting together a follow-up modulation discussion tomorrow afternoon. So hopefully he's get the chance to describe that some more if we have 1 minute left. But first is the scientific questions. So that was a very nice study that was presented also on NHP. So where it was shown that you can interfere by focusing in the prefrontal cortex and interfere with the network. So one of the questions was, how is this, how will be the network activity related to the behavior outcome? And how do you think about enhancing specific functions of that brain region?
Hi, Elisa. Hi, Shongshik.
Hi.
Great seeing you here. This is a $1 million question, right? Can we use ultrasound to enhance brain function?
Well, we left it for you.
Yeah, that's very easy. So we're just gonna tune it this way and the other way, but slightly more seriously, that is particularly tricky. It is relatively easy to perturb and interfere with the brain region, specifically not just with the region itself, but with the computations that it's going to perform. Whatever you're going to do, it's much easier to mess it up. Nonetheless, to enhance a high-level function, something you could do is actually inhibit competitive computations and help to try to rebalance the system. So that's an approach that many people in psychiatry are taking to indeed enhance function. But to super boost healthy human function, that is a lot more tricky as well. In non-invasive brain stimulation, this is the holy grail, and whoever tries it until now fails. It's just incredibly difficult to make superhumans. But Elisa, you were also mentioning tomorrow at the end at the round table, I think many of us are getting together to discuss guidelines and safety of ultrasonic neuromodulation, specifically in humans. So the round table will be open and we'll be communicating further through that channel. So thanks, Elisa, for giving me the opportunity there.
Thank you, Leonard. Elisa. And Shongshik, I forgot Mehmet, so
right.
I'm so sorry.
I can introduce Mehmet and ask him some good questions because I do have burning questions for him. Hi, Mehmet. So Mehmet Özdas from Zurich presented a super interesting technique to using aggregation and uncaging of a drug delivery to do a lot of neuromodulation and including other applications. So for those who are not familiar with the method, how would you please give us the remaining 1 minute time to explain to you how to make the drug aggregate and uncage them?
Yeah, so we provide very low ultrasound pressures, and this inside the capillary, this is causing like primary Birkning forces, which makes the bubbles oscillate in phase, and they aggregate together through a secondary Birkning forces. And when they aggregate, it becomes harder because they form a shell. It becomes harder for the primary Birkning forces to reach the core. So as long as we sonicate on the aggregate, they keep aggregate together. But once we turn off the ultrasound, they will join the stream. And the way that we uncage, we apply on the aggregated bubbles, we apply a very short pulse of higher amplitude ultrasound, and that uncages the drug.
Thank you so much. Unfortunately, we take the conversation to tomorrow afternoon. Hopefully I'll see you guys then. And thank you so much for all this exciting work and presentations. Thank you, everyone. Bye-bye.
Thank you.